excited to have you all here. This event is co-hosted by the California Pan-Ethnic Health Network. We are a statewide multicultural health advocacy organization focused on eliminating persistent health inequities and addressing structural racism in healthcare, including mental health care. Just a few housekeeping items. Next slide. So just wanted to go over a few housekeeping items here. Please change your name, your Zoom name, to your full name so others can see who you are. Please use the chat box. For folks that are joining right now, introduce yourself in the chat box and tell us your name, your organization, your pronouns, and share with us why you joined the mental health briefing today. Please post your questions to the speakers in the chat box. CPEN staff will be facilitating your questions during the Q&A, and access relevant materials, including speaker biographies, via the links that CPEN facilitators will post in the chat box. So the chat box is your friend today. Please interact with each other. All right, so moving on to the goal of today's mental health briefing. We have 4 goals today. Oh, and if you're not speaking, if you could please mute yourself. Thank you. We have 4 goals today. The first goal of today's mental health briefing is for us to talk about the impact of COVID-19 and structural racism on the mental health of communities of color. Our amazing opening speaker, Dr. Leandra Clark-Harvey, is going to provide opening remarks on the issue. The second goal of today's briefing is to show that mental health disparities are real, they are persistent, and they are current. Our amazing Executive Director, Kiran Saved-Sangwan, will lead us in that presentation. The third goal is to showcase local programs that are actually reducing mental health disparities. Our Community Advocacy Director, Mihei Jung, will moderate the discussion of 3 local programs that are actually doing the work. And our last goal is to zoom out and look at the broader landscape of mental health budget and policy in California. Michelle Dari Cabrera, the amazing Executive Director of the California Behavioral Health Directors Association, will lead us in that presentation. What we really want to emphasize about today is that racial equity must be at the core of addressing mental health disparities. Solutions are not out of reach, but in order to do this, we need to have a grasp of what the disparities are, what's already working and showing positive mental health outcomes in communities of color, and the broader mental health budget and policy landscape. So that's what we're going to do today. All right, so now let me introduce our amazing opening speaker, Dr. Leandra Clark-Harvey. She is the Chief Executive Officer of the California Council of Community Behavioral Health Agencies and the Executive Director of the California Access Coalition. Dr. Clark-Harvey holds unique experience and intersectional roles as a practicing psychologist, policy advocate, and statewide representative of behavioral health agencies. We are so lucky to have her join us today. Please join me in welcoming Dr. Clark-Harvey.
Good morning, everyone. And I'm the one that feels really lucky to be here, I must say. Really excited and energized by the comments that I see coming into the chat box. So I know many of you are also excited about the work and the conversation that's going to ensue today. So I'm Leandra Clark-Harvey, the CEO of the California Council of Community Behavioral Health Agencies. And I'm honored to have this opportunity to address this group this morning. You know, CBHA represents a wide variety of nonprofit mental health and substance use abuse providers across the state. And we work closely with our partners to advocate for the needs of vulnerable populations. And CPEN is one such valuable partner. They are leading the statewide efforts to reduce health disparities. So I'm always happy to endorse the great work that this organization does, particularly during this racial pandemic. And there's not a better time to partner together again than the present, for sure. You know, we're all experiencing the effects of this global pandemic. We know that the health of our nation is on the line. And when you look at racially and ethnically diverse and underserved communities, we see that these groups are hardest hit by the pandemic. These communities have the highest rate of job loss, highest rate of COVID contraction, and highest death rate. from COVID. This is problematic. Health disparities are magnified during this time in a way that we haven't seen before. And as we grapple with how to shift the way that care is delivered, we're also experiencing this racial pandemic that I mentioned earlier. Social unrest surrounds us, and there is a reckoning to change the way that corporate America is doing business and government as well. So just yesterday, I heard Will Lightbourne, our leader at DHCS, say this quote: "Systemic racism does not occur incidentally. We have to engineer our systems and our settings to provide culturally competent care that is perceived as a tool of justice, a tool of justice. We need to look at our care and think of it that way." And Will is right on. We have to recognize the problems that exist, but move from just mere acknowledgement to solution-focused strategies. And that's what I think the ending conversation today is going to be about. So in order to do this, though, we all have to understand what role we play in maintaining the systems that bolster structural racism. We have opportunities to come together and promote change. There's new federal leadership on the way and policy change at the state level via our upcoming 1115 waiver and specialty mental health waiver design process. I don't think that you can have movement unless everyone is rowing together, so to speak. So today, you're going to hear from leaders who are committed to making change during this very unprecedented time. I think of this pandemic as our modern day civil rights movement. And I'll tell you that I want to be able to tell my children about how I showed up and advocated for the needs of vulnerable communities during this time. I implore each of you to consider how you will look back and reflect on what you did to make a difference in ameliorating health disparities and combating racism. So thank you again for the time to speak to you. I look forward to a highly productive meeting and really want to make sure that we think about the concrete steps during these conversations that California decision makers are going to take to advance behavioral health equity.
Thank you so much, Leandra. Tool of justice, that's exactly right. How are we going to tell our children and our families what we did to show up for our communities? Thank you, Leandra. All right, so next up, I'd like to introduce our CPEN's Executive Director, Kiran Savage-Sangwan. Kiran has been the chief architect of many CPEN bills. She has been instrumental in positioning CPEN as a leader in the health equity field, including mental health. So Kiran today will be presenting data on racial disparities in Medi-Cal mental health, which CPEN published in partnership with the California Healthcare Foundation. Please join me in welcoming Kiran.
Thanks so much, Carolina. I'm really thrilled to be here and thrilled to see everyone who's joined this morning to have this really important conversation with us, and particularly want to thank my friend Leandra for just those powerful opening remarks, as she always does. I think really drawing us up to what is the big picture here and where are we trying to go. So really appreciate your participation. So I'm just here to give a kind of short overview of data and what we see in the data in terms of inequities and injustices in our mental health system, specific to our Medi-Cal program, which, as most of you are probably familiar with, provides healthcare, including mental health care, substance use treatment, and dental care for many of our low-income Californians, and serves a majority people of color in the state of California. So if we go to the next slide. So just as a reminder for folks who are learning about the delivery system, in Medi-Cal, we deliver mental health care. And I will just say as a preface, we really are focused on mental health care here today. There is an entire conversation that we can and should have about substance use as well, but we're really focused on mental health today. And so in Medi-Cal, we deliver our mental health care through two different but related systems, right? And that's our counties, our county behavioral health departments, who provide what some people refer to as specialty mental health care. And this includes things like inpatient psychiatric services. I will note too that our counties do also provide a range of other mental health services outside of the Medi-Cal program. So some of you might be familiar with the Mental Health Services Act. Our data doesn't get into that part of what counties do, just because that data is not available to us, but want to flag that for folks. The other part of our Medi-Cal mental health system is our health plans. So, in the Medi-Cal program, we have health plans like Kaiser, we have health plans like the health plan of San Mateo. Those are all health plans who also have a responsibility for providing mental health services, but a slightly different kind of mental health services than the counties provide. So our health plans provide services to people who need what sometimes is referred to as more mild or moderate or care for more mild or moderate conditions. And the counties take on responsibility for consumers who might require a higher level of need for their mental health concerns. I will also, I always have to caveat several things. I'll also say that children's mental health is a very specific issue that, again, we don't get into as much today, that there are some differences there just for folks to be aware of that. Next slide, please. So at CPEN, we believe that data is imperative in terms of really recognizing what is the experience of consumers, where do we need to look, how do we improve our systems, that what we measure really tends to be what we pay for and where we focus, and that historically, we don't measure things in a way that reflects communities of color, right? And so in 2017, we sponsored a piece of legislation that was authored by Assemblymember Arambula, who you will hear from if you join us tomorrow, really to say, when we think about mental health and we think about what we're going to report and collect in the state of California, we must have a focus on disparities, and we must be able to look at that data by racial and ethnic population as well as by language. That legislation was signed into law by then Governor Brown. We worked with stakeholders in the field to develop recommendations for implementation, and the Department of Healthcare Services published the first data set in 2019, and then an updated and expanded data set is also coming this year. Next slide, please. I think we can go to the next slide. So what do we see in the data that we have? So this shows you just across the entire Medi-Cal population, the number of people who are receiving services, mental health services specifically. And so what you can see here is that in our county system, it's about 3.8%, nearly 4%, right, of our enrollees in our Medi-Cal program. That number has gone down a little bit since 2014. And if folks will remember, in 2014, we got a significant increase in the number of people in the Medi-Cal program due to the Affordable Care Act and the Medicaid expansion. 2014 is also when the health plans started having this obligation to deliver their part of mental health services. Since then, we have seen a slight uptick in the number of people getting services from their health plan. In the most recent year of the data, about 2.5% of people are getting those services. Next slide, please. So what we see here in terms of the number of people who are being served receiving mental health care through either system does concern us, because it appears to fall far short of the number of people that we believe do need mental health services and are enrolled in our Medi-Cal program. So what you see here in the orange is the number of people in our Medi-Cal program who receive any kind of mental health service, either from the health plan or from the county. What you see in blue is our best estimate based on some national data of the number of people who really have a mental health condition or experiencing a mental health challenge and need services. So you see that very significant gap between the orange bar and the blue bar, and that it hasn't moved a lot, right, in the last 4 years. So really, when we think about our policy changes later on, we want to think about how do we move that needle. Next slide, please. So when we think about mental health, we also recognize that most people, mental health doesn't tend to be a sort of one and done type of healthcare service, right? It tends to be something that people need sustained engagement over the course of a period of time or even their lifetime. So we also look at the number of people who receive 5 or more mental health services in a year, which is what is commonly considered an engagement, right? And what we see here is that in both the managed care and the county mental health system, those numbers are low. They're lower than we might like to see them. But we do see some differences between the two systems. And primarily, we do see that the county mental health system does have higher rates for engagement than our managed care system. Next slide, please. So this is where we're able to start to look at disparities by race. So what you see here in the blue bars is the people who are served in our county or our specialty mental health system by race. This is the sort of best data we have on this. We recognize it might be incomplete, but this is, I think, tells an important story. What we see in the orange bar is the people who are served in our managed care or health plan system also by race. So what you see is that there are differences, right? And primarily we see really low rates of utilization in our Latino and our Asian and Pacific Islander populations. We also see lower rates of utilization across all populations in the managed care system than in the county system. And in particular, I would point to the really big difference between the utilization rate for our Black consumers in the specialty system and in the managed care system, which may point to a problem of particularly our Black community not being able to get into mental health services earlier in their experience of a mental health challenge, which is a problem we'll want to unpack. Next slide, please. So again, this shows when we look at the engagement rate by race, and we continue to see the same trend. We continue to see Black Medi-Cal enrollees using services at a higher rate, but using services at a very low rate on the health plan side. And we continue to see our Latino, Asian, and Pacific Islander enrollees using services at some of the lowest rates of all groups across both systems of care. Next slide, please. And here we delve a little bit more into specifically the health plan system. And one of the reasons that we look at that is because we actually believe that's where many people should be receiving their care, because that's a system that will provide people care earlier when their level of need is a little bit lower. That's a system that will provide things like individual therapy and family therapy and medication management. And here we see really significant disparities as well. And so I will just note, this looks at the number of services provided. It doesn't look at the number of people who receive services, right? So that's still a question we have outstanding. But what we do see is that white Medi-Cal enrollees receive many more managed care health plan services than enrollees from any other demographic group, and that non-white Medi-Cal enrollees use services at less than half the rate of white. And so I'm going to sort of stop there with the data, but I think, you know, what we want to emphasize is that while the data has gaps, we do believe it tells a really important story that we need to pay attention to in terms of policy making. And we believe that that story is also sort of supplemented by what you'll hear in the next discussion about the experience of people in communities, of our providers, of our consumers, and some of the challenges that they experience, but also some of the, I think, really incredible solutions and practices that communities have developed to start to close some of these gaps and move us towards racial equity. I'll turn it back to you, Carolina.
Awesome. Thank you so much, Kieran, for that amazing overview of our delivery system, the data, as well as some of where we need to go with that data as well, and the real experiences of people who are doing this work on the ground. All right, so we have a poll question. This is an opportunity for participants to engage a little bit. We are curious to hear from all of you how the data presentation Kieran just shared resonates with you and resonates with your experience in working with diverse Californians. So we're giving you a minute to answer this question. Do the racial disparities reflect your experience working with diverse Californians accessing mental health services? So please take a minute to answer the poll. Awesome, interesting. All right, so looking at the results here, and it looks like the overwhelming majority of people on this call are saying yes, that this data on racial disparities and mental health is reflecting your experience working with diverse Californians accessing mental health services. So approximately 80% of people on the call are saying yes, about 5% are saying no, and about 16% are saying maybe. Really, really interesting. All right, thank you so much. All right, if we could move on to the next slide. Thank you. All right, so up next we have our roundtable discussion, which is really going to make up the bulk of our conversation today. So our roundtable discussion is moderated by Mi-Hye Jung. She's up here on the left if you're looking at the pictures. Mi-Hye is our amazing community advocacy director. She leads our coalition work here at CPEN. She works closely with our grassroots partners to identify strategies for mobilization and ways to improve access to mental health care that are community driven. She will be joined by 3 panelists from county and community programs to discuss what they're doing to promote racial equity and mental health care. Anna Gorman, who's the Director of Community Partnerships and Programs for the LA County Department of Health Services. In that role, she runs the My Health LA program, which is the county's healthcare program for low-income residents who don't qualify for health insurance. Second, we have Tracy Lacey, who's the Senior Mental Health Services Manager for Solano County Behavioral Health Department. Tracy is responsible for the community program planning process, as well as the MHSA 3-year plan, centerpieces of our public mental health system. And third, we have Gulshan Yousefzai, who's the Executive Director of the Muslim American Society Social Services Foundation. And she oversees one of our amazing community-defined evidence programs here in California as part of the California Reducing Disparities Project, California's largest culturally responsive mental health initiative funded by the Office of Health Equity. Again, please share your questions in the chat box. CPEN staff will be moderating the chat box to grab questions, and CPEN staff will also be sharing materials related to the speaker's programs during the roundtable discussion. We will have a 10-minute Q&A at the end of the event. All right, Mi-Hye, I'm going to pass the mic over to you.
Thank you, Carolina. Hi, everybody. I'm so happy to be here sharing this space with you guys. My name is Mi-Hye Jung. I work as a community advocacy director with the California Pan Ethnic Health Network, CPEN, and I'll be moderating this discussion today. So I'm very excited about these programs. I think these programs are really, showcasing rubber meeting the road. So we have 3 programs to share with you all from across California that are currently working to reduce mental health disparities in communities of color. We hope that sharing these 3 programs with you, that they inspire you, that they give you ideas. They give you ideas for what can be done, and that they inspire you to leverage your positions and wherever you are to start change, right? So across California, as Kieran talked about with the data piece, we continue to see the worsening of mental health disparities in communities of color. And so as we continue to do this work, we must remember that these disparities are not intractable, and that mental health structures that were not made to serve the distinct needs of our communities. Diversity in California is our strength, it's not our weakness. We know that one-size-fits-all approach to mental health access or any health access and services does not work. We should consider how to address the mental health needs of different cultures to ensure that the mental health needs of everybody are met, and we have an opportunity to do better. So the goal of today is to introduce you these 3 programs that are currently reducing mental health disparities in communities of color. And we're going to be talking about how data inform the development of these programs, why culture must be at the center of the programs, and the possibilities for future scaling and possible replication in different counties. And so we'll be doing a Q&A portion at the end of the event, and we have Monica who's monitoring the chat box. So throughout our roundtable discussions, if a question comes up for you, you can just put that in your chat box and at the end. And if you're, each of the speaker also brought materials with them and PowerPoint presentations. We're not going to be casting those presentations like on the screen, but all those PowerPoint presentations available on our website. And so you can take a look at those materials to learn more about these programs. Great. Okay, so now I'm going to have our panelists introduce themselves and their program. And so we will have each of you, so we have Anna, we have Gulshan, we have Tracy. Hello, hello, hello. So we'll have three of you share your name, your pronouns, your position at your agency, a brief description of your program, including the population or community, your program services. So let's take 3 minutes for each of you to answer that question. So let's start with Anna.
Great. Can everybody hear me? Okay, perfect. My name's Anna Gorman. I'm the Director of Community Partnerships and Programs at LA County DHS. Thank you so much for having me. This is such a great discussion and such an important topic. So before I tell you a little bit about the specific mental health project, let me just give a very quick overview of My Health LA. So My Health LA is a health coverage program for uninsured, low-income LA County residents who don't qualify for public insurance. DHS pays community clinics to provide primary health care to this population. And then if they need urgent or specialty care or emergency care, they come back to our facilities, the Department of Health Services facilities. So that's an overview. We have about between 130 and 140,000 participants in the program. And though we do not ask immigration status, we do know that they are not, they don't have legal immigration status because they don't qualify for full scope Medi-Cal. So this project that we launched officially in July of this year, this summer, and it's funded by the Department of Mental Health. So it's a partnership between LA County DHS and LA County Department of Mental Health and the community clinics that we contract with. It added a new mental health benefit to our program. So our participants can now receive mental health prevention services at their clinic. And the services include things like coping skills, stress management, psychological first aid, and soon grief and loss. These are provided by anybody actually at the clinics. It did not have to be a licensed clinical social worker or an MFT or a psychologist, psychiatrist. Anybody who received the DMH training could provide these services. And we know that there is a tremendous need for these services. So we're excited to be able to offer them. So I'll stop there and then answer more questions throughout the discussion and explain a little bit more about how we came to launch this and how it's going so far. Thank you.
Thank you, Anna. Great. Let's go to Gulshan. And just to remind you your question, share your name, your pronouns, and your position at the agency, a brief description of the program, including the population that you're serving.
Let's oh my goodness, and I forgot. I'm so sorry, I forgot to say she, her. My daughters have trained me well, but I still always forget. So thank you.
All right.
No
Can you all hear me?
Thank you, Anna.
Okay. Well, thank you, Mihai and CPAN for including me in part of this very important discussion, especially with what's happening with California. My name is Gulshan Yousafzai. I'm the Executive Director with the Muslim American Society Social Services Foundation. A very long name, so we're known as MASS SSF. My pronouns are she and hers. MASS SSF is a nonprofit in Sacramento that provides 5 programs to keep families together. This includes our peer counseling program, a program for seniors, a youth warm line, community education workshops and trainings, and a recent program we just started in July for youth that's TALED regarding it's an advocacy program. So most services we provide are in English, Arabic, Dari, Pashto, and Urdu. Those are just some of the main languages, although there are many in our community, in the MENA community. Today, I will go ahead and discuss outcomes of our programs that aim to reduce mental health disparities among the Muslim and the Middle Eastern, South Asian, North African, and of course, any and all ethnicities that exist in the US, because the Muslim community is vastly, is huge in terms of ethnicity. And so through training and use of our culturally responsive peer counselors that we have, I'll go ahead and talk about those outcomes today, hopefully. And also, I just want to say that MASTEF is the only program that actually serves the Muslim community. We are located in Sacramento, but you know, we are open, our services are open to all, but given our team, we have, you know, whether it's our whole team actually are consisting of refugees, immigrants, and represent majority of the ethnicities I just named. And we're funded by the OHCRDP, Office of Health Equity. I need to stop with the acronyms. California Reducing Disparities funding until 2022 for our peer counseling program. And then our community education, we recently received funding from the county through CalMesa. But then our other two programs rather, are through donations through the community, and that's been since 2007. So that is MASTEF, and I look forward to participate in the rest of the program. Thank you.
Great. And Goldstone, just for clarification, when you say MASSFS or SSF is the only Muslim serving organization, is that in California or is that in Sacramento?
That is in Sacramento. I would say also California in terms of mental health. So we do overall social services, but our focus is mainly mental health. And so as to my knowledge, we're the only nonprofit in California and probably outside of California that is focusing on mental health for the Muslim community.
Gotcha. Thank you so much. I think that is a very important thing to note, that it is the only organization for Muslim populations focusing on mental health issues. Thank you.
Thank you.
Great. So let's go to Tracy.
Hi, thank you. So good morning. My name is Tracy Lacey. My pronouns are she, her, and hers. I'm a senior mental health services manager and the MHSA coordinator for Solano County Behavioral Health. And today I was invited to talk about and share one of our MHSA innovation projects called the Interdisciplinary Collaboration and Cultural Transformation Model. I dare you to say that 5 times really fast. This is a 5-year project funded with innovation funds. We are delivering this project in partnership with UC Davis Center for Reducing Health Disparities, 3 CBO partners, and the community in general. This project is focused on increasing access for 3 historically underserved communities in Solano County, the Latino, Filipino, and LGBTQ+ communities. The project is anchored in the National Culturally and Linguistically Appropriate Service Standards, community engagement models, and the Quadruple Aim framework. As a result of this project, we have 14 quality improvement QI action plans, and these were developed by community members. And I hope to get to talk a little bit more about these QI action plans. They are focused on community outreach, workforce development, and training. So I'll go ahead and stop there and let us get into the questions. Thank you for inviting me today.
Thank you so much, Tracy. I'm so excited to hear about your programs. I think for Solano County project, I've been personally tracking and following, or maybe stalking, your program for now 2 years. There's been an article written on California Healthcare Foundation about how you've been able to reduce disparities and you know, really build consensus on, you know, focused population with collaboration of county and communities and CBOs. And so I'm just really looking forward to hearing about that. And, you know, having Gulshan, you know, explain what the California Reducing Disparities Project is and how monumental that is in California. I'm excited to hear about that. And Anna, I think your program's unprecedented trailblazing effort to capture this, you know, folks that are in the shadows, you know, we don't know who they are and we don't know what their needs are. And so I think I'm really excited to hear about how you've been able to, you know, undertake that challenge, especially working in LA County. And I know personally, I live and work in LA County, and it's huge. And so I'm curious as to how that all worked out. So we will move on to kind of more deeper discussions about your program. And then towards the end of our discussion, we're going to have panelists also discuss some recommendations for all the attendees in terms of how the attendees can be inspired to potentially, you know, scale up or to connect with attendees or to our panelists today, so that you can have your discussions within your teams, within your departments, within your counties. So let's get into the questions. So the first question for the panelists is, what gap does your program seek to meet? And what is the data that informed the start of the program? So what data did you encounter that made you want to design the program the way that you did? And where did you encounter the data? How did you find that data? And so make sure the question is, what gaps is your program seeking to meet? And what is the data that really got you going in the first place? And we'll start with Anna.
Great. So the gap was clear. We knew that there was a need for mental health services for our population across the spectrum. Our patients receive care at 52 community clinics across LA County. Some of those are robust clinics that actually do provide some mental health care to their patients, regardless of immigration status or insurance status, but others weren't, and it wasn't equal across the board. We also knew that immigrant communities have faced a lot of fear and anxiety and depression. Most of this honestly has been anecdotally or by qualitative data surveys, and not necessarily unique to the undocumented or uninsured immigrant population. There's been increased deportations, federal policies such as public charge changes that have increased anxiety. And of course, all of our participants in My Health LA are low income. So there, on top of that, there was poverty and everything that comes along with poverty that increases stress and anxiety and depression, food insecurity, unemployment. All of that, of course, on top of that, heightened because of COVID. Our participants in My Health LA, many of them don't have severe enough mental illness to qualify for services through the county. They aren't on Medi-Cal managed care, so they can't qualify for mental health treatment for the mild to moderate. And we had a limitation because we were using DMH's Mental Health Services Act dollars, which had to pay for prevention, not treatment. So this isn't treatment. So we went to look at how we could do that, and based on the data that we could find. The problem is, as you heard earlier, this is a population that has been living in the shadows. We don't know much about this population and their needs. We were able to find a few studies here and there. There was one, a very small one of about 250 people, undocumented immigrants near the California and near the Mexican border in California, about 23% of them met the criteria for depression and anxiety. And so we found a few studies like that, but they were very small. So we really are hoping that our project will produce some data that will help guide other programs in the future. We are not doing a randomized controlled trial. We are not doing a super rigorous analysis, but we are looking at the data closely. And part of our project is a universal screening with the PHQ-9, which is a depression screener. So all My Health LA participants are supposed to get screened with the PHQ-9, and we will be measuring whether or not these services that they receive have an impact and reduce those scores. So hopefully you will see some data from our program that will be helpful for the future.
Thank you, Anna. Just a quick follow-up question in terms of like the data piece. When do you think that you would be able to share out some of this data that you're speaking of?
So we officially started the program at the beginning of our fiscal year in July. We want to get through a year of the program before we release any data. And we'll talk about this later, but there've been some challenges because of COVID. Not as many patients are coming into the facilities. And even though a lot of these services can be and are being done by phone, the uptake hasn't been as high. So we want to give it a little time. And there's also, of course, some translation challenges and so forth. More than 90% of our population are Spanish speaking. And while the goal was to address these risk factors for developing mental illness and build these protective factors, we have to, so they don't, so they can be resilient, we need to get through a little bit of time and make sure that people are receiving services over time before we know that it indeed has met that goal.
Excuse me, thank you so much, Anna. That's really helpful, and I'm really looking forward to just following your journey with this program. So thank you. So let's go to Gulshan. The question is, what gap does your program seek to meet, and what's the data that informed the start of the program, and where did you find that data? And feel free to talk a little bit more about the California Reducing Disparities Project if you think that talking about that is relevant to the question.
Sure, thank you, Mihai. So just first of all, in terms of Sacramento, we all know it's very diverse, but when you look at the Muslim and non-Muslim community, it's become even more diverse. And so you have a community that is vast in ethnicities, but like I said, are Muslim and non-Muslim. So just as an example, and I want to provide this because it's generally not understood, you will have Arabic speaking population here that are from probably 14 to 22 countries, right, that exist in the Middle East. However, they're not all Muslim. So you have Muslim and non-Muslim. And I mentioned this because one, it's not understood in that way. And second, there's, when it comes to your wellness and accessing services, that's an important thing to understand. But in addition to that, you have communities from South Asia, Pakistani, Indian, you have, of course, refugees who have existed for many, many years, since the 70s, 60s, and so forth, but more since 2014, there's a huge influx of refugees from Afghanistan and in Syria and Iraq, and now Sacramento has become one of the main cities nationally that is receiving and continuing to receive refugees. And saying all that, when you look at services, they don't really exist to meet the needs of these communities that I just mentioned. In terms of the gap that our program meets, so like I said, we have 5 programs. The one I want to talk about is for this question is the Shifa for Today peer counseling program. So, peer counseling programs are all throughout the United States and many in California. What makes us unique, or what fills in the gap for us, is that our peer counselors represent the community, the vast ethnicities that I just mentioned. And in terms of a lived experience, a language, so at our agency, we represent over 10 languages. However, we focus on the top 5, with English as one of them, because of the population that's high in those numbers. When you look at ethnicities, of course, our peer counselors, we have trained 42 peer counselors since 2016 to provide services. So the community, when they call for services, they will see someone that they recognize that look like them, but also be able to seek services and have that one-on-one in the language that they're most familiar with, because like I said, given the ethnicity, there's huge number of language issues. So in that way, our counseling program fills in that gap. And of course, cultural and spiritual need. Most of our peer counselors are Muslim, but we also have non-Muslim counselors. So of course, in terms of healing and moving towards recovery of an individual who's going through challenges, we want to make sure that we're able, when a community member calls, we're able to match them up after we do an intake to the individual that they're most comfortable with, whether it's because of the culture, of the religion, because of the language, and that's where the first step is. In terms of healing starts, they're comfortable, they trust the peer counsel that they're talking to, and that's part of, when it comes to peer counseling and being evidence-based practice, and it shows that it's extremely effective. It's because of these components. So that's pretty much what makes us unique in terms of our program. In terms of data, so when we talk about data does not really exist in an appropriate way for the Muslim community. So, like I said, there's a vast, diverse group. And so in terms of data, it's been extremely hard. We have been around since 2007. We started as a volunteer run, and like I said earlier, 3 of our 5 programs are still volunteer, and we really rely on that. But we started because we saw that there were no programs. However, families were having lots and lots of difficulties. Suicide was going up also. And this is through evidence in the community, as well as divorce rates were going high. So when we're talking about how did we inform the program we started, well, since 2007, we've done a needs assessment. And since we are connected and well trusted by the community, we were able to focus on that in terms of lived experience from our stakeholders. One of the reasons that this program, so Mihe, before I continue in terms of time, I would like to bring in CRDP at this point. Just want to check in with you in terms of timing.
Yeah, I think you can bring CRDP now.
Okay. So in terms of CRDP, it's a program that I've actually been involved with since 2009 in my various roles in my career. So it's a demonstration project that shows community-defined practices that actually work. Many times, services are provided through evidence-based programs, but CRDP really does business differently, and through the leadership of Marina Augusto at the Office of Health Equity, this demonstration project really started out in 2009 in phase 1 to focus on the 4 ethnic and 1 and also LGBTQ community, to really look in there and see what works, what really helps these communities to seek services, to improve their wellness, to go towards recovery, move towards recovery. And so they did full reports for about 3 years on the African American community, Native Latinx, Native American, LGBTQ, and African American. And so again, the goal here was, let's go to the community that knows what works for them and give them an opportunity to be able to tell us this, but also then provide them the funding in phase 2, which started in 2016, to be able to go ahead and put that in practice and implement. But another component in terms of doing business differently compared to many grants that are given for services like this, they wanted to, the CRDP program wanted to go ahead and provide technical assistance for agencies like the one I'm running, MASSEF, who has been volunteer run. So of course, when you're volunteering run in terms of capacity, developing your infrastructure, none of that exists really because you don't have the funding. And how do you go ahead and implement a community-defined practice that is actually going to render results if you don't have the infrastructure? So CRDP has done an amazing job of providing the expertise in terms of technical assistance, funding to have agencies like the one I'm running to be able to develop the program and actually have an evaluation process. In terms of, it's a program overall that's ahead of the curve. And I believe it's the only one in the United States that exists in terms of just looking at underserved communities, looking into that and actually asking the community what works for you, and then giving it enough funding, I don't know, I shouldn't say enough funding, but funding to be able to look at the program and actually develop it, evaluate it, and then hopefully by the end of the project, which is in 2022, see if it works. Collect evidence for it to be eventually moving forward towards evidence-based, and to show that programs like this actually can work if you actually work with the community who knows what they're going through. So I'm going to stop there.
Thank you, Gulshan.
You're welcome.
Thank you. Yeah, for attendees that are curious about the California Reducing Disparities Project, CRDP, there's some information that we're dropping in the chat box. The CRDP project is funded by the MHSA, Prop 63, and it's the largest and the only demonstration project like in the country that really lifts up community-defined evidence-based practices and adding research and evaluation rigor to that. And Loyola Marymount University was chosen to be the one conducting evaluation for the 35 demonstration projects. And so it's a very exciting project, and we have a lot of information out there for this, and so we're going to put this in the chat box. And I think it's interesting to know, Gulshan, that for this population also that there was not data, a formal sense that we're calling it data, right? Data with a capital D. But just by being in the community and being part of the community, you can see and feel what's going on, and if there is, needs that are being highlighted, and you can really see that. So there's, I think the data on the data piece sometimes, is there data or is there not data? That's also like in the eyes of like a beholder. So thank you, Gulshan. Okay, so let's go to Tracy. Thank you. So Tracy, the question is, what gap does your program seek to meet, and what's the data that informed the start of your program, and where did you find that data? And if you want to speak on that, more of the beginning piece, that would be great.
Thank you. So our project is really focused again on the 3 priority populations, the Latino, Filipino, LGBTQ+ communities. For the Latino and Asian Americans, specifically large population of Filipino community members in Solano County. At the time that we started this project, they were the penetration rates or access to services was very low, historically very, very low. And for the LGBTQ community, they're widely understood to be underserved, though in Solano County, we really didn't have data around that. So the gap that we're trying to meet is really increasing access to healthcare services, and particularly early on, rather than waiting until people are in crisis and coming through our crisis stabilization unit or hospitalization. And so really kind of addressing the stigma in those communities. So the data that we used when we started again was the state, the EQRO or DHCS penetration rates that are calculated based off of your county's population, your county's Medi-Cal eligible population, and then the services that are being billed through the Department of Healthcare Services. I do kind of want to underscore a little bit that that data is kind of not complete, in that it's not capturing the services that are being delivered for the uninsured communities. So if they don't have Medi-Cal, that data, we are putting services in our electronic health record, but those are not billing up to the state. So it's not a complete picture. Also, Solano County is one of the special unique counties that has what's called a Kaiser carve-out. So we have folks that have Medi-Cal Kaiser insurance, and they can opt to get their services through Kaiser. So again, the penetration rates that we all look at with EQRO and the state don't necessarily include that data either. But what we knew is that the Latino and Filipino or Asian American communities were historically way underserved, and it had been continuing for years and years. What we knew is that we weren't solving it on our own. So we actually started doing community engagement before we even knew exactly what that meant in terms of, we brought together work groups of folks that represented those communities. We asked them for feedback around what we should do. And so this is really how this innovation project was really born. And again, like I said, we didn't have good data for LGBTQ community. We had trained our staff on having those conversations, collecting information, but we were putting it in fields that were more like narrative boxes. So folks were identifying what their sexual orientation was or their current gender identity, but it wasn't in a field that we could pull the data out and kind of analyze the data. So we ended up inserting fields into our electronic health record in 2016, actually before NetSmart actually inserted it. I think they came a year or two after us. So we knew that it was important to start really capturing and looking at who we were serving. What we knew for the LGBTQ plus community is if we weren't collecting that data or looking at it, we probably weren't really providing culturally responsive services. So that's how those 3 priority populations came to be identified for our project. And again, the data was pulled from our electronic health record, from findings from community themselves. Also, part of MHSA is annually or more frequently, we do community engagement through our community program planning process. So we gather information directly from the communities we're serving around how we're doing. And so we continued to hear that we needed to have more diverse staff. We needed to have more linguistically appropriate services. So that's kind of how the project was born. Hopefully I answered your questions.
Yeah, and can you talk a little bit, and you mentioned innovations, and there might be folks on the line that may not know what that is. So can you talk a little bit about what innovations is and how that played a key role in forming your program?
Thank you for that. So there's different components or funding components in MHSA. There's the prevention and early intervention, PEI, there's community services and support, CSS funds, that's kind of the biggest funding component, but there's a special little pot of money called innovation, and it requires its own community program planning process, its own plan. It's the one funding source where we actually put together a project in partnership with feedback from the community, and we bring it before the Mental Health Services Oversight and Accountability Commission to get approval before we can even start a project. And so innovation funds are generally used with a focus on underserved, marginalized communities. How can you increase access and finding new innovative ways to improve processes? And so we're the first project that is incorporating the culturally and linguistically appropriate service standards, the CLAS standards, with community engagement models and QI action plans that are actually developed by the community members themselves, by these 3 priority populations. So typically innovation funds can only be used for 3 years. We got special approval for a 5-year project. So we're in year 4, or excuse me, 5th year. We're in the 5th year of the project. So implementing the QI action plans that were developed and evaluating. So I think a question that's coming up will let me talk a little bit more about the evaluation.
Awesome. Okay. All right. So thank you, Tracy. So yeah, thank you everyone for kind of briefly talking about your program and the role of data in the genesis of your programs and what that was. So Anna, can you talk a little bit more about, you said earlier on the COVID-19, the impact of COVID-19, and I think that's relevant to bring up right now, and in terms of the implementation of the program, and can you speak a little bit about the challenges in collecting data as well?
Of course. So let's see. We had an all provider in-person meeting in LA County on March 4th to launch this program. So everybody remembers March 4th being pretty normal, except we did get a question, interestingly, from one of our clinics that serves primarily a Chinese speaking population, asking if there was any way we could move it to a virtual meeting. And I naively said no at that point, that no, we were going to have this in person. So we were planning to do our final, have our contract signed the very next week and launch on April 1st, do training in March and launch on April 1st. that did not happen, obviously. So one was just the simple delay. Number two challenge was that the clinics were dealing with so many more important things or more pressing, not more important, but more pressing things with COVID, including just simply trying to figure out how to keep their doors open, how to keep their staff, how to switch to remote operations and telehealth. So starting a new project that was really kind of complicated on mental health prevention was really just not at the top of their priority list, as you all can imagine. So we delayed it. And then once we did finally get some engagement and the clinics thought they were ready to start, then we were able to do more training and get everybody ready to start on July 1st. But even now, there remain challenges. So I don't know how many folks are from health centers or how many folks are actually providing care directly on this call. But the patients that they were seeing just didn't want to come in. And honestly, we're told not to come in. So that created a challenge, because the idea behind this project was that providers would talk to the patients when they came in for their primary care visit and say, let's do a screening, let's see if you might benefit from these new services. And that just wasn't happening. So it had to become more proactive, where clinics were actually calling patients and doing screenings over the phone and doing primary care visits and trying to figure out how to hand people off. It also just became a little bit harder to publicize this. Like, we created these cool flyers to put up in clinics, and we just, obviously that just didn't really work. So we did our first ever text campaign from My Health LA, and we included stuff about COVID, and then we did another text and a robocall about these new mental health services. So we're hoping that that will kind of increase some uptake, and we're trying to just figure out other ways to engage the My Health LA participants in this, because it's just, even though we know there's so much need for these stress management services, we just are having trouble engaging. So I think all of those are challenges because of COVID. And then the data collection itself is hard, because this is all new for the clinic. This is creating the workflows around this has been new, and we had them put scores for the PHQ-9 on their claim forms so we could collect data for the Department of Mental Health, and they had to do programming. So as in any new project, like if I were in the same room with all of you all, I would have you raise your hand if you've started a project. And then I would say, raise your hand if you've had problems with that project and implementation and fidelity. And I think everybody's hands would get raised. And then if you say, we launch a new program, the unprecedented in the middle of COVID, will you have problems? And I think you'd get like double hands raised. So all of those have created challenges. We're working through them. And in fact, we're having an all provider call with the Community Clinic Association right after Thanksgiving to work through some details of implementation.
Thank you, Anna. I think the true partnership is really what comes up for me with the My Health LA. It's just to serve this very, shadowed folks that, it's a partnership between Department of Health Services and Department of Mental Health Services and the community clinic folks. And it's really amazing. And, you're at the inception, the beginnings of launching this program. And so again, I'm curious to follow the program and see the outcome eventually. Yeah. So thank you.
Yeah. And the one last thing I'd say is that we also rely, in addition to the clinics, the Community Clinic Association, and our partner DMH, we also rely on organizations like yours, which was integral in the coming up with the idea for this project and in giving us feedback on the development of the project. So I think the community organizations that also care for this population have been really important. And that would be a recommendation for down the line, is just make sure anybody who's launching any sort of project on mental health and should work very closely with the community organizations who know the population you're working with better than you do, and definitely better than I do.
Thank you, Anna. So let's talk more about outcome and evaluation, and we will move then towards, having you guys talk about recommendations for the 77 people that are on the call today. And so Gulshan, can you talk a little bit about the outcome piece, right? Like this whole briefing is about reducing disparity. So have you found data, within your program that have reduced disparities? And can you share more about the outcome data piece, whatever you have so far?
Sure. Thanks. So as I said earlier, this program, the peer counseling program, is it's designed to report out on the outcomes that we collect as of 2022. But so far, the outcomes of our program that we seek to achieve, I'll talk more about that, would be number one, building individual and community capacity to thrive. So as part of this, also reducing stigma so our community can access services, and then also to support and strengthen family systems. Those are the outcomes that we're focusing on through having our peer counseling program. In terms of just building individual and community capacity, it's in the Muslim community, you don't go outside of your family to generally seek services. And a lot of the Muslim community are here from trauma, from countries where they have lots and lots of trauma. And then, of course, that trauma is doubled, or maybe added to, I should say, when they come to the US and they experience Islamophobia or lack of resources. And so for those reasons, our services that we provide for peer counseling focus on the prevention piece and intervention piece in terms of course, as I mentioned earlier, having peer counselors that are culturally competent and actually look like the community that they represent. And when I say community, again, it's almost every ethnicity, including the community of LGBTQ that we include and we have in the Muslim community. Also in terms of reducing stigma, we do a lot of community education trainings and workshops, whether it's our mental health first aid training to help community members recognize early signs of individual with challenges, or providing workshops and trainings in the 5 languages I mentioned. Our hope is that we could create enough awareness to be able to educate the community that it's okay to seek help. And it's always been okay. Of course, they have to overcome the idea of being from a community that says, where they're used to, that you stick within your community and you don't go out, you stick within your family, you don't go outside of that. So it's getting used to the individualistic system in the US that exists. So in terms of reducing stigma, our community education efforts are huge, and the number of workshops and trainings that we provide. And then strengthening and supporting family systems, whether it is with resources that we provide them, linkages that we make on services that we cannot offer right now because of capacity. That's another need that we have. And so in all of these areas, in terms of outcomes, our goal is to build that individual community capacity and reduce stigma and hopefully develop or offer enough communication services that our community is able to seek services and feel comfortable and trust the mental health system, because of course they all come in here with a lot of issues from back home, but then even being here, it's very difficult to go outside of your circle and seek services and actually believe that it's going to cure you, it's going to help you. And with the peer counseling program that the CRDP has funded, our hope is that we are able to provide, we already have the trust of the community clearly, but we're hoping that they're able to access these services and actually see the results. And one last thing I want to say in terms of outcomes is majority of our community members that exist in Sacramento, whether it's because they came here in the 60s, 70s, or the ones that, especially the ones who have come since 2014, the refugees, we are really trying hard to have them understand why it's important to seek services. And this is specifically because they come in with so much trauma. And at this point, one of the reasons we are using the peer counseling model is because it is, and this is how we got funded from Office of Health Equity, is that we believe this is the model that would help our community to not get to that clinical aspect. Of course, there will be a number of our community members who are at that point, but majority we believe are not. And so through our workforce development evaluation focus that we have through this program, we're hoping to collect enough data and outcomes by 2022 to show that that these individuals from these communities will access services and not get to that clinical aspect in terms of where they are in their lives.
Thank you, Gulshan.
You're welcome.
Great. So thank you. Tracy, let's go to you and have you talk a little bit about the evaluation aspect that you wanted to talk about. And as you talk about evaluation, can you also fold in some recommendations for other counties that are here of what they can do to do what you did and to do what your team did?
Great, thank you. So the entire project is heavily weighted in evaluation. So the first year, UC Davis Center for Reducing Health Disparities did a comprehensive health assessment with the 3 priority populations. So key informant interviews, focus groups, community forums, surveys of CBO partners serving the 3 different priority populations. They took the findings from those that health assessment. They created narrative reports for each of the 3 communities. They're posted on our website. I call it the report card. A reminder, this was done in 2016, so we've made lots of headway in changing things to address the feedback that we got. Those narrative reports were done again for the Latino, Filipino, LGBTQ communities in English, Spanish, and Tagalog. And so those findings were then kind of merged with the class standards. A Solano specific training curriculum was developed that was provided for 3 training cohorts of multi-sector folks, law enforcement, behavioral health providers, faith community, local education folks, public health, child welfare, you name it, all with lots of emphasis on representing those 3 priority populations. And those groups then developed quality improvement action plans. We have 14 of them. Hopefully you'll be able to check out the slides to see some of the QI action plans. And so the whole goal here is to really kind of increase access for these 3 priority populations, increase service utilization again. So folks calling our access line when they're starting to experience symptoms rather than waiting and coming through the crisis door. Decreasing stigma in these communities. So there's lots of stigma in all 3 of those communities. Increasing consumer satisfaction. So UC Davis is twice a year, the mental health plan does state surveys. So they did a baseline kind of evaluation, and they'll be doing another one before the end of this year on consumer satisfaction. We're looking at decreasing costs. And then also part of the quadruple aim, something that people often leave out, is provider satisfaction. So to serve communities and really address disparities, you have to kind of be supporting your workforce best you can. So we implemented, and this is something counties can do, we implemented a workforce equity survey in 2017. It was something I had to work really closely with HR on, because we're asking questions that usually you're not allowed to ask as an employer. And we've been doing that again since 2017, and we've inserted into that survey questions around satisfaction with their job, and do they feel supported in working with marginalized communities. And we've seen good outcomes so far. So we have seen a 7.9% increase in service utilization for the Asian Pacific Islander communities. We've seen a 16.8% increase in service utilization for the Latino Hispanic community. And then for our LGBT community, we've seen a 425% increase in callers who identify their their current gender identity as something other than male and female. a 666% increase for callers who identify their sexual orientation as something other than heterosexual. So we're asking those questions, those demographic questions on the access call. So we're normalizing it. We're putting those questions into our intake questionnaires that folks are filling out. So if we don't get the information at the call, we're getting it at the intake appointment. So really lots of effort around the lobbies and having visuals that represent all communities. I'll just share one little thing. Our youth FSP program started putting rainbow stickers on their badges, on their county cell phones, and on the dashboards of the county cars. And within like 3 weeks, a bunch of kids self-disclosed their current gender identity or sexual orientation. So it can be something very simple that can be done. And yeah, the QI action plans range from, we have 35 culturally responsive school-based wellness centers now, K through 12 and adult ed sites across Solano County. We have an LGBTQ ethnic visibility poster campaign. You can see some of those in the slides. We have a class gap finders where now we have put into our contracts, we require all of our contracted CBO partners to do their own cultural responsivity plans. So that they're starting to implement class into their systems as well. And I think that's something that counties can do pretty quickly if you become familiar with the class standards. They're very straightforward. Community agencies, counties, any kind of organization really. We implemented the class standards in our contracting and our RFP process and all of our policies that we're updating and any new policies. So that's something, once you start to see this lens, you can't unsee it. You really start to live and breathe what you need to do to have a more culturally and linguistically responsive system of care. So yeah, that's kind of in a nutshell. It's a huge project. And when you guys were talking earlier about the impact of COVID, absolutely has impacted the QI action plans. A lot of them had to be delayed. Posters that are supposed to be going up in clinics and in restaurants and in grocery stores, and we're getting those out right now, but there's just been some delays in some of that because of COVID. And then just for our project, and I'm sure many other projects, and in this period of time, we had a lot of emphasis on immigration and people that were afraid to come into a government building because they thought we would call ICE. So we've really seen kind of some fluctuations, and that we've had the outcomes we've had is just phenomenal and speaks a lot to the community engagement aspect of this project.
Thank you, Tracy. I think something comes up for me is building out the new norm, you know, and that takes effort. And that takes effort from, you know, putting a rainbow sticker on your phone all the way to building, you know, QI action plans with the community, right? And so I think it's the sense that, you know, it's a collaboration and a consensus building approach, I think is another norm that needs to be replicated if we are serious about reducing disparities. And so thank you for sharing that. Great. So Anna, what recommendations do you have for other county safety net programs that do not currently offer mental health services?
Sure. I think a few things. One I alluded to before is to really work with the community organizations and the community itself before you even conceive of launching a program. A lot of this, thankfully, was actually done by my predecessor, Amy Luftig-Visti, before I came on board, where there were listening sessions and a work group to talk through this. So I think that was really important in guiding what we wanted to do and where the gaps were. A second one would be to really work to get a champion in wherever it is that can make these decisions happen. So for us, one of those champions was in one of the Board of Supervisors offices in LA County, and he really got the support of his boss. He was a health deputy for one of the supervisors, and really got the support of his boss and of the supervisors as a whole. And with the board in LA County, for those of you who are in LA County, you know, if you have the support of the Board of Supervisors, you're golden, right? You can move forward and they can help move things. So I think getting that champion and keeping that champion on your side is really critical. I think another recommendation is to be creative, right? So we knew that we could only, because we were using MHSA prevention and early intervention funds, we couldn't pay for treatment. We couldn't use this money for treatment, but we could use this money to support the infrastructure of the clinics that were already providing mental health services by adding this extra element. So we just had to be creative and trying to figure out what we wanted to do. And then the fourth one is to try to make it as easy as possible for the people who are implementing the services. So for example, we knew that the clinics were worried about having the right staff and getting paid enough to be able to have the staff to be able to provide these services. So we made it easy. Working with DMH and DHS, we decided that no, you didn't have to, like we talked about, we didn't have to have a highly qualified, licensed, certified person. These are conversations about stress management and breathing skills and coping skills and things to help people gain just some resilience during a very difficult time for immigrant populations. And in some ways, I think we will show that it will work better because some of them are community health workers or even medical assistants or social work interns who are training. So we had to be creative and we had to work with the clinics to make things flexible. We thought initially that we would create our own screening tool. And it turned out that the clinics that didn't work for the clinics. They didn't want another screening. And many of them were already doing the PHQ-9 depression screener. So we made it easy for them in that way. And also providing the training for them. So instead of saying at the beginning, we said, well, clinics, come to us, tell us what kind of prevention services you want to provide. You guys can create your own curriculum. That was too much. That was a heavy lift. So Department of Mental Health, they're the experts in this in LA County. So we had them, they offered and they did develop these short video trainings on these areas. So I think those are some of the recommendations that I would make. Everywhere is unique, and LA County is so massive that I don't think you can necessarily replicate anything that's been in LA County elsewhere, but you can definitely learn from some of our already early successes and early challenges / opportunities if you're thinking about doing something like this in the future. And I have to say, in LA County, the last thing I will offer is that we are also really lucky that there is so much support for a program like My Health LA, which I've already described the population that we serve. You couldn't do the same thing in other states and in many other counties around the state. So we are fortunate to be able to have an investment in mental health prevention for a population that is vulnerable and underserved. Thank you.
Thank you, Anna. I think there are amazing recommendations for counties, and I know that there's some folks from the state, Department of Healthcare Services, state advocates that are on the call today. And so for you, I encourage you to make connections with a panelist and explore ways to, make it easier for programs like these to implement and to find opportunities to scale up, right? And I think that's really, as a state advocacy group at CPEN, that's something I always look for, is, what are the programs that are working in these local regions, and how can we find opportunities to scale that up? So thank you so much for sharing that. And so I'm looking at the time, and it's already 12:25, which is really, that sort of flew by, and so we're gonna actually start now the Q&A section of the panel, and there's actually a lot of questions that have trickled in, and so I'm gonna need to sort of sift through But one question for Gulshan here is that I have worked, so we're now officially starting the Q&A part of the panel. And so for Gulshan, I have worked with API mental health providers in LA County and share the same struggle on data for AA, NHPI, as well as the cultural competence concerns for our communities. I wonder, with peer counseling, how do you deal with countering cultural stigma while maintaining cultural familiarity?
So in terms of peer counseling that we provide, it's really working directly. Can you repeat the question? I'm sorry, I don't think I got the whole thing.
Yeah, so the question is that this person who asked the question, they've worked with the API mental health providers in LA and share the same struggle on data for AA, NHPI, Asian American Native, Hawaiian and Pacific Islander population, as well as the cultural competence concerns for the community. So they're wondering, with peer counseling, how do you deal with countering cultural stigma while maintaining cultural familiarity?
How do I counter culture? Okay, so I think for us, what we've done, I could tell you that, and hopefully that will bring some light to it. In order, peer counseling and peer specialists, as they're generally known as, are programs that are throughout the U.S., as I said earlier, and certainly in California. What really makes our group, our program rather, more unique is working to recruit and having a very extensive recruitment process when community members that you're going to eventually have go through the 90-hour peer specialist certification to become a peer counselor. So for us, we do an extensive recruitment in terms of an application process, interview process, and really interviewing them and seeing why do they want to become a peer counselor. I think that's something that's been very helpful in developing our workforce. Actually, our evaluation focus for this program is workforce development and really seeing, developing a number of peer counselors and then having them be trained in peer counseling where they get certified to learn about peer counseling, how to use peer counseling concept to help individuals go through towards recovery. But then another thing we've done as part of our evaluation is we've developed a curriculum that will, and we just adopted it and provided the training that would help peer counselors who could help our communities in terms of whether you're Muslim, and from the vast ethnicities that we represent. So it captures concepts from and knowing all the backgrounds of the cultures that they are serving. So if a peer counselor is Arab and is serving, let's say, someone who's Spanish or Mexican from Latin community, they need to know the background. They could counsel as an Arab counselor, but if they don't know the background of Spanish community, how are you going to really connect with them? So it uses our curriculum and training that we've developed focuses on understanding the cultural backgrounds, also language, of course, because that's a barrier, that's always an issue. Also the belief system, and also working with understanding what refugees go through in terms of trauma and really understanding that. So extensive recruitment process, learning the backgrounds, the culture and religion, and any other belief that they may have is one of the things some of the things we've done to make our program successful. And of course, all of that requires you to work very directly with the community and have a good knowledge and get input constantly. The stakeholders are constantly involved at every level, whether it's evaluation, you have community members, whether it's the counseling, you have community members. At every level, we have stakeholders from the community who help us develop our program to make sure we are constantly up to date in terms of needs. So hopefully that answered the question.
Thank you. I know that there is a question in the chat box. How can we learn more about that peer counselor program. And if Monica, Carolina, if you don't mind dropping in Shifa for today information, I think if you scroll up, Jose, that there was a one pager that Monica dropped earlier. So you can take a look at that. Thank you, Gulshan, for your answer. And I think there is one question that that was kind of posed for everybody. And I will just lay out the question, and Tracy, Anna, and Gulshan, if you want to sort of grab the question and answer it, you can do that. The question is, in developing each of your programs, how has your agency or your organization and your team worked towards decolonizing mental health so as to not perpetuate the harm mental health has historically done to communities, especially communities of color, and also I'm going to add LGBTQ populations as well. So the question is, how it feels conceptual, the nature of the question, but you can provide specific examples. And I think the example that Tracy, you had about developing QI action plan with the community, to me, that's one example where that's decolonizing the process, right? But yeah, so in developing each of your program, how has your agency and your team worked towards decolonizing mental health so as not to perpetuate the harm mental health, I guess, systems have historically done to communities and LGBTQ communities and communities of color? And so it's an open-ended question for you three, and if you'd like to grab it and run with it, go for it.
I could start if you like. Okay. So, so in terms of the response, I would say the whole peer counseling concept comes from the peer movement. And the reason that started, I believe it was in the 60s, was because of the harm that was being created in the mental health system, specifically whether it was clinical, well, it has always been clinical until peer specialists or peer movement started. And so that's where peer counseling started from. And what that basically means is individuals who were hospitalized and were given very limited choice in terms of recovery, and that in clinical terms is generally treatment. Now in peer counseling, they have a choice in terms of how they think that their, well, the mental health difficulty they're going through can possibly, heal and possibly the support that they need. So I think the whole concept of peer counseling, peer specialists, it started because of this, where individuals were being harmed by the services or the mental health system. So I think that's, in terms of at Mass SSF, what we do is we talk about this to our clients, but we also talk about, we're very transparent in that we are using community members who are like you, who have been through what you've been through, and are now trained to the peer certification training that OSHPED offers throughout the United States. And that gets them to learn how to counsel these community members. But on top of that, we are teaching our counselors the curriculum we developed, which is how to use the values of the cultures, of the religion, of working with refugees in terms of trauma, and using that to help them further. So I think in terms of the harm that the mental health system has created, I think peer counseling has proven that, and that's what we use. And a lot of our community members really connect with this because of what they've seen already, coming from many of these countries that have been in turmoil or even here, and then being able to actually connect to individuals who could connect with them on level of lived experience, cultural, religious, or ethnicity or whatever. So I think that generally, all those pieces really help our community members to understand that peer counseling does work, and it works for people who have been through a lot of these difficulties that generally make them think that mental health, or their experience might be that mental health system harms them.
I would just,
Thank you, Gulshan.
Yeah, I just offer just a couple of quick things. One, for the My Health LA mental health prevention services, they were available to everyone. So they are available to everyone. So there's no gatekeeping involved. I think that helps. Also, having them available at the clinics, the places where they trust, where they get care, where they go and have gone, their families have gone for a long time. They don't have to go somewhere else to receive these services. I think that was another way we were able to do this. And designing them to be culturally sensitive. So in this last curriculum that DMH is developing on grief and loss, they really tried to get feedback from the clinics who were serving these populations and incorporate some of that into the grief and loss curriculum, so that it wasn't just grief and loss from DMH's perspective, it was grief and loss from the community's perspective. And so it included stuff about how the Latino community and immigrant communities refer to loss, and what are some of the bigger losses. And finally, in our materials, we actually don't call we just don't even call it mental health services. We say, are you feeling sad? Are you feeling stressed? We can help you, so that we try to get away from that stigma that mental health services have.
So, and
Thank you, Anna.
if I can just add a little bit to, yeah, I think community driven or community informed QI action plans, where they were really developed by the community instead of a bunch of government workers sitting in a building trying to come up with ideas, because clearly that didn't work, has really helped folks feel more comfortable. Several of the QI action plans do have like a peer focus, and like our mental health education QI action plan is training for youth and faith communities, and training youth pastors like in mental health first aid and suicide prevention models to recognize when someone's in trouble, and like the sustainability of that. So training the communities how to help themselves, but also in tandem training them how to access our services when they actually need them, early on rather than later. The school wellness centers is another really great example. These are access points. So these are not, these rooms have art stations, yoga stations, places where kids can have a cup of tea. It's not a therapist sitting there necessarily doing therapy with them, though that's available if that's what they need. And there were youth focus groups done on all the school campuses, and the young people said peers, they want peers there. So we're working with the school districts. They're a little uncomfortable with that, but we're trying to help them be more comfortable with young people being able to be in the wellness centers, helping each other. So I think those are things that kind of help with decolonizing mental health and making it more accessible.
Thank you. Yeah, I think it's just sometimes it's about the small things, and sometimes it's legislation, right? It's all of the above. So thank you so much. There's actually way more questions, but we don't have time to get to all of those questions. And so I think what I encourage all of you, the attendees, to do is to connect with Tracy, to connect with Anna, to connect with Gulshan. And if it's okay, with your permission, we'd like to put your contact information if you find that appropriate, so that people can reach out to you directly to learn more about your programs. And this is just a start, right? We're opening the door, and then it'd be great if, folks can walk through that and start to work together. So this kind of wraps up the panel part of the briefing. So sincere gratitude to Gulshan, Anna, and Tracy. Thank you so much for your work, and thanks for being here.
Our
Thank you.
pleasure.
Thank you.
Thank you.
Thank you. I think I'm passing the mic over to Carolina. Oh, Carolina, you're muted.
Oh, thank you. Thank you all so much for that really thoughtful, detailed discussion and data-informed discussion about how we can actually reduce disparities in communities of color. I am so excited for our next presenter. Up next, we have Michelle Dottie Cabrera, who is the Executive Director of the California Behavioral Health Directors Association. Michelle has a wealth of experience on state budget and policy prior to joining CBHDA, she was the healthcare director for the California State Council of the Services Employee International Union, also known as SEIU California, where she advocated on behalf of healthcare workers and consumers, including, very importantly, county's behavioral health workforce. Michelle's going to give us a really broad overview of California's mental health and budget policy landscape, where we are today. So we're going to zoom out a little bit. And Michelle, are you on?
I am. Hi, good afternoon.
Good afternoon. Awesome. Great. And you'll be sharing your screen, correct?
That's right. Sounds like you can hear me. So let me just pull that up. And get the show started here. So it sounds like everyone had a really great presentation earlier, and thank you so much to CPEN for inviting the County Behavioral Health Directors Association to be a part of today's briefing. In my presentation today, I'm going to cover the ways in which COVID-19 has impacted behavioral health services and funding, particularly for communities of color in California. I'm going to talk a little bit about the state policy landscape as it relates to behavioral health in California and some of the bright spots on the horizon for behavioral health equity specifically, and then some of our membership's recommendations for California policymakers and how we can address the looming budget crisis for behavioral health. And I just wanted to note that behavioral health financing is distinct from the state general fund. So we'll talk a little bit about that. So first, let's dive into COVID-19 and what kind of impact that's had on our behavioral health system. Recent and ongoing data from the Department of Public Health shows that COVID-19 is hitting communities of color much more acutely, both in terms of overall infection rates, particularly for Latinos, Native Hawaiians, and Pacific Islanders, but as well in terms of death rates. And again, Latinos and African Americans are particularly impacted, along with Native Hawaiians and API folks. They are dying at disproportionately high rates. Part of this is a reflection of structural racism and the fact that Black, Indigenous, and people of color are more likely to be suffering both economically and facing job loss, but also be essential workers who must be out in the community and exposed to the virus on a more ongoing basis. One other thing that I'd like to point out as it relates to the seriously mentally ill population served by county behavioral health is that folks who are seriously mentally ill are more likely to live in poverty and not have the same sorts of employment and education opportunities as their counterparts. So diving a little bit into, this is national data. These are some surveys that were conducted both by the CDC as well as the Kaiser Family Foundation. What we've seen since the pandemic started is an uptick in anxiety, depression, substance use disorders, as well as suicidal ideation. The Kaiser Family Foundation study found that 40% of US adults reported symptoms of anxiety or depressive disorder as of June 2020, and that was up from 11% the year before, and it was already starting to climb in May. We also see that folks are reporting that they've actually taken up substance use or increased their substance use since the pandemic started with that CDC data. So we know that there's a concurrent looming epidemic of behavioral health conditions that are triggered by stay-at-home orders and also the economic distress and impacts, as well as just seeing your loved ones have to deal with illness and the fears that come along with that. County behavioral health really jumped into action shortly after the pandemic, and I would say we were more quickly impacted by the pandemic in many ways because our system is both fee-for-service and cost-based. So unlike Medi-Cal managed care plans, which get a steady per member per month, no matter what, our folks, once folks went to stay in place or shelter in place, excuse me, or quarantine, and they were unable to bill for substance use services or mental health services, that really turned off the funding flow from Medi-Cal in particular. And so we had to, as a matter of survival for our system, for our contract providers, as well as our county providers, really jump into action very quickly and make sure that we kept those services available by adapting to telehealth modalities. And so we worked quickly with the state to be able to make some of those changes that were needed immediately. And that's why we focused a lot on early days on regulatory changes that were necessary. Client and workforce safety has been a ongoing problem. And I think, this will be a theme throughout the presentation, but just to say that while policymakers were very focused on the needs of the healthcare delivery systems for protective equipment, for infection control protocols and guidelines and the like, this is one of those areas where having different regulators being sort of differentially situated certainly impacted us. We were not at the front of the line, even though we continued throughout this pandemic from the beginning until now to offer in-person services. And this is really important when you think about where many of our clients live, the fact that many experience homelessness or really just need that in-person engagement and or services to maintain their recovery. And so we've kept up our critical in-person and field-based operations. We were very careful, again, to make sure that we were also creating policies and workarounds to help keep our contractors afloat, all the while our folks were trying to relieve pressure on the emergency departments from the beginning of the pandemic. Some of our counties have been doing really great work in providing emotional support and counseling to frontline workers, such as skilled nursing facility staff. And then we're involved in some of the broader community crisis counseling, so that emotional support that comes along with warm lines and those sorts of activities. At the same time that we were sort of handling all of our day-to-day responsibilities that I just outlined, the state has also been engaged in trying to decompress and divert. I think those are the two words that I would use. The California Department of Corrections and Rehabilitation has faced waves of COVID outbreaks, which have put both the lives of inmates as well as staff in those prisons at risk. And so they've been releasing tens of thousands of low-risk inmates throughout the pandemic. Many of these inmates have significant behavioral health needs, and I will highlight here the substance use disorder needs of these populations. The folks at CDCR reported that they're thankfully offering Narcan to all the inmates who they're releasing, and they've got a significant uptake on that. It's approximately 60% of inmates leaving CDCR are taking that offer. Where we're less prepared is sort of for that warm handoff in the community. And again, I'll give kudos to CDCR for saying that they've done great work in recent weeks and months in working to bring us to the table more closely. But this has not been without sort of its challenges, again, because of the needs and the numbers of folks. The state also launched Project Home Key and Project Room Key, which are intended to help provide temporary housing and then permanent housing to individuals facing homelessness during the pandemic. I will call out here that while County Behavioral Health has been at the table providing on-site services to those individuals, this program was not designed with County Behavioral Health clients in mind. And so individuals with some more serious mental health and substance use disorder needs are often not top priority for these housing slots. And so our folks, and particularly some of the more difficult to serve of our clients, are not getting captured in this existing allocation of housing resources. I'll just jump over children and youth really quickly and add in on the state hospital side. The state hospitals essentially went on lockdown to try to prevent introduction of COVID-19 through the end of May. And for folks who may be less familiar with the state hospitals, the populations that they tend to serve are the more acute, seriously mentally ill folks. So we're talking about folks who are on who are being conserved under the Landrum and Petra Short Act, or individuals who have been found incompetent to stand trial and are trying to be restored so that they can go back and face those charges. So this is a very high needs population. The state hospitals have in recent months also experienced COVID outbreaks and have been working to try to lessen the introduction of COVID, deal with the wait list of folks who are trying to get into the state hospitals, and also looking to the local level to absorb more of those clients' needs. None of these efforts have brought with them new or dedicated resources to county behavioral health, but we are expected to serve the state hospital population, individuals experiencing homelessness with those serious needs, as well as folks coming out of CDCR. In addition, our folks have seen significant increases in need for children and youth. I'll talk to that a little bit more in a next one of my upcoming slides. And again, because of the challenges that we've had with infection control, given that many of our clients are served in congregate and residential settings, we've had ongoing outbreaks as well of COVID, which has made those step-down levels of care more challenging for folks to access, and it just creates that sort of bottleneck both at the emergency departments and as we're trying to address those higher needs folks. Again, think about county behavioral health really as the safety net for folks who are most significantly in need of services. On the fiscal end of things, we estimated over the summer that between the summer of 2020 and the summer of 2021, we would lose around $1 billion in revenues. This is across our major sources of funding, so realignment funds as well as Mental Health Services Act. We got some flexibilities through regulatory relief, which really were helpful to us in deploying telehealth and, like I said, getting Medi-Cal to work for us, and also helping us to restructure some of our contracts. We also asked for regulatory help and statutory changes related to the Mental Health Services Act funds so that we could use those funds more easily. I'll just say for folks early in the pandemic, because tax payments were deferred, we had months where our Mental Health Services Act revenues were down by 60% at the height of the pandemic, or the earlier waves of the pandemic, I should say now. And then we fought alongside other county entities for a backfill of those estimated lost realignment resources, and were able to get roughly a fourth of what we estimated we would lose. Again, I'll talk a little bit more about those fiscal impacts moving forward. What we've seen in recent months, and this is across different counties, is that since the pandemic started, and these numbers vary, and it's really hard to tell why and what's going on underneath, but what I can tell you is that counties are reporting a 2- and 3-fold increase in young people experiencing mental health crisis during the pandemic. We've seen intermittent and across different parts of the state spikes in both suicidality and deaths by suicide. Again, really hard to make sort of a sense of what's going on in terms of why and where. In some cases, these spikes are with individuals who are privately insured or not. Historically, clients of county behavioral health, in some cases, they are our clients. We've also had reports from county behavioral health directors of increased rates of fentanyl-related deaths, overdoses, excuse me. So we're seeing an increase there as well on the substance use disorder side. our clinicians do have concerns with telehealth in some populations. For some folks, it's led to, you know, fewer cancellations, higher participation, you know, fewer no-shows in certain types of activities and appointments. But in other cases, like with some of our more acute clients, we're really watching closely to see if it's effective and or if effectiveness wears off in the long term when you're trying to apply telehealth in a sustained manner, and really trying to do a lot of cross-system learning and sharing there. I do want to call out that while all of this is going on, we also, as you all know, got hit by the wildfires in California, which had a significant impact on our systems, as it impacted both our workforce as well as our clients. We had facilities serving behavioral health clients who had to evacuate and move clients. And this is just an ongoing challenge with collective layered trauma in wildfire impacted communities.
Hey, Michelle.
What are some of, yes.
Hey, this is Carolina. I just wanted to let you know that we have a couple more minutes.
Oh, okay. I'll try to go quickly then. Let me see. One more thing on COVID-19, just that there's a study out this month that shows that individuals who have COVID are way more likely to get diagnosed with a psychiatric disorder 90 days after their diagnosis, and also that people with mental illness are more likely to be diagnosed with COVID-19. A lot more to learn there. In terms of the state policy landscape, I wanted to say a few things. First of all, county behavioral health resources, which are reflected here in the dark blue portion of this bar, are significantly lower than Medi-Cal as a whole. And yet we're expected to serve a variety of populations across both Medi-Cal and non-Medi-Cal populations. And this is our estimate for where we think our finances will be in the year ahead. Of note, our 1991 realignment, which funds a lot of those, is our most flexible pot and funds a lot of the things that we can't fund with Medi-Cal. It's below 2004-05 levels in the next year. And there's kind of a delayed reaction on the fiscal end with the Mental Health Services Act. And so while our estimates for the upcoming year are lower than in prior years, we think it's going to dip even more as we head into 2022, 23. I won't get into too much detail since we're pressed for time on sort of the whys of how our financing contributes to some of the disparities that we see in funding for county behavioral health. But I will make one point, which is that Medi-Cal really is only part of the story. Outside of our Medi-Cal reimbursement, we pay for so many things that are central to equity, like outreach, engagement, prevention, funding for community-defined practices, housing and homeless services, our mobile crisis response teams, as well as those activities under Mental Health Services Act that are not matched by Medi-Cal. And this is significant when we try to have a Medi-Cal oriented conversation about what's happening for behavioral health safety net consumers. Medi-Cal really is not designed today to lead the way on equity. But as you can see, when you look at the full picture, we have much more going on in county behavioral health. One bright spot is the Newsom administration and the fact that for the first time in a long time, equity is being centered as well as behavioral health within the administration. This is long overdue and again, very welcome. CalAIM is going to be one of the most transformative initiatives that we've seen in a very long time in behavioral health. There are a lot of jargony terms up here, but I'll just say outside of the usual conversations on whole person care in lieu of services, et cetera, there is major transformation on the horizon for county behavioral health systems under CalAIM. I wanted to share a little bit about how our county behavioral health directors are prioritizing and thinking about the future. First is we have a sort of an overarching set of priorities, funding stability and adequacy, as well as equity, justice, and healing. And I'm so proud of the work that our directors have done in leading conversations at the local and state level on equity. While we are far from perfect and we have a lot more to learn and do, I do think that there is a lot for health systems more broadly to learn from county behavioral health as we evolve together. The other thing that I wanted to point out is that aside from CalAIM, we are also looking ahead in the next couple of years at reforms in the crisis continuum with housing and homelessness, as well as in terms of children's services and school-based services. We see on the horizon opportunities to partner with the legislature and the administration on really starting to address structural racism that is baked into Medi-Cal and our county behavioral health systems, and look critically at those systems to see how we can adapt and change them so that they are meeting clients and community in their wisdom and expertise. The state has put on the table a population health management proposal under CalAIM for Medi-Cal managed care plans, but we really think that we need to have population-based behavioral health focus as well, and move toward the decriminalization and deinstitutionalization of individuals with behavioral health needs. For funding, we need to make sure that while these services are realigned, they're not forgotten. Our behavioral health system, as I pointed out with our 2021 funding levels be below those of 2004, we really need to right size how we're funding this and make sure that people understand the full range of services that are being delivered to help prop up our Medi-Cal beneficiaries' services, which are, again, have been underfunded. And we need dedicated housing slots. I cannot assume that housing discrimination is not a thing, and that people with serious mental illness and behavioral health needs are going to be served in those efforts. And finally, I know you talked a little bit about this earlier, but we will be working very hard to implement SB 803, the Peer Support Specialist Bill, which we co-sponsored, to make sure that peers in California are implemented in a way that really serves the interests of equity, as well as under CalAIM. So with that, I apologize for having to try to cram so much here into a short amount of time, but I really thank CPEN for letting me share with all of you, and thank you so much.
Thank you so much, Michelle. I know there is so much to share about the budget and policy landscape in mental health, and we got a taste today. We could definitely do a full series on it because there is so much happening right now, and so many opportunities to get this right for our communities. So that concludes our day one of our mental health briefing. Thank you all so much for joining. Just a couple of reminders. If you're interested in hearing more about other programs that are providing data-informed solutions to address mental health disparities, come back tomorrow. We have some new presenters. If you're interested in hearing from thought leaders, foundations, legislators about what they're doing to address structural racism and COVID-19 in mental health, come back tomorrow. We will have a really robust discussion, new presenters. I will be your moderator. And if you haven't signed up for our mental health newsletter, please do so. So you can check out on this screen, we've got the registration for day 2, as well as registration for our newsletter. All right, thank you all so much, and see you tomorrow.